I saw this really cool Darth Vader costume.
No one's wanting to pay attention, so it's all.
Sorry.
Darth Vader, what?
I got a.
I was gonna say do the one.
One level? Three times. All right.
You can do me, Mr. Art class.
What about Darth Vader? What?
There is a coffee mug that I saw that I think you like.
Oh,
Big old Darth Vader
I
head.
always like a new coffee mug. Lots of them.
Yeah.
All right. Well, I'm just going to start talking. Y'all can write if you want to. So we left off talking about the two hip projections, and we're going to now go on to our hip projections, of which there are four essential projections: our regular AP, our lateral, which has multiple names. And all those names can be lateral, medial-lateral projection, and Lauenstein and Hickey methods. Hickey method. Lauenstein and Hickey. Yeah. All right. Then we have the axiolateral Danielius-Miller method, everyone's favorite in lab. And then the modified axiolateral, or the Clements-Nakayama modification. That's a fun name for these, man. Clements-Nakayama. And this one right here is basically an alternative to Danielius-Miller, where we can't move either of the legs. So we're going to see if there's a way that we can still obtain that cross-table lateral. Although it's not as optimal, there's an alternative means of doing so. Now let us start with the AP.
You should know them by these fancy names.
You do need to know, you always need to know the names and the methods.
Is
So is it Land, Plant, and
Lauenstein.
like is that one? Or the
Yeah,
two?
Lauenstein and Hickey, they put two names on there. That means two
okay.
different people
Danielius-Miller is a cop,
formulated
right?
methods, they put both their last
Yeah.
names on there.
is the
You should know
Clements?
that.
You know, like how you have multiple
I know,
authors on
but I'm saying like it's
Same thing.
the Clements Nakayama. Is that another comp as well?
No.
Like a mandatory one?
It's just an alternative method of getting the Danielius-Miller. Danielius-Miller is mandatory.
Could we do the Clements in place
Which
of
I'm sure
it?
some of the seniors are doing right now because they're in capstone right now. Like really stressed out.
He said, really got it.
You know, it does not, and it bugs me because there are lots of opportunities to do this X-ray, and we're gonna go over it. There's lots of opportunities to do that X-ray, but so many techs are intimidated and scared to do it. And I don't know why. It's a great X-ray. I do it all the time for kids. Huh?
If I just think, oh, I'm gonna do it, and then give it to a doctor, and then make sure I'm not.
I'll be very grateful because it's a great X-ray. Too many techs are like, well, it's the patient couldn't move. They make excuses and fill out documentation, couldn't obtain the lateral, patient in pain. They're just very intimidated by that X-ray for some reason. I don't know why. I don't think it's that bad. It's a very pretty
I think
X-ray.
the name
You do it
sounds
right.
more intimidating than.
Like Julius Miller. All right, so AP hip. Of course, once again, just like everything in this chapter, guys, we're never going to be doing these standing up. Everything we do is supine, 40-inch, in the table bucket or a grid if it's portable. So for this one here, guys, just like with the pelvis, we want to watch for that rotation of the pelvis. Make sure we're nice and perfectly supine, because what I tell you guys, people will naturally do when they're maintaining their hips, they're going to shift that weight. If they shift that weight, as we saw in those pelvis X-rays, what's going to happen to the pelvis? It's going to distort. Do you remember how it distorts whenever we're rotated? The olives are going to change in size, and what else is going to change in size? On the bottom. No, not the lesser trochanters. That has to do with feet. The obturator foramina. So, when you rotate the hip, if I'm going to an LPO position, the left olive will get larger, the left obturator foramen will close. It's opposite on the other side. If I turn to the right, RPO, right olive enlarges, right obturator foramen closes off. We'll see that when we start reviewing some images. It's a good way to tell the patient has shifted their weights. And you can tell which way they shift their weight based on the shape of that ala and how this obturator foramina look in comparison. So we'll see that when we do some evaluation of the images moving forward in one of your future classes. But back to the hip, I'm off on a tangent here. We're going to medially rotate the lower limb and foot approximately 15 to 20 degrees. Now, why do we do that? That's similar to what we already talked about. Why are we always turning that foot in? Where are you wanting to hide?
The less
We're gonna hide the lesser trochanter and put the femur in a true AP. We'll hide that lesser trochanter. Put the greater trochanter in, as we say, profile. Now also, just like with the AP pelvis guys, this is gonna place the femoral necks parallel. Very important point there. So greater trochanter is in profile, femoral necks are in parallel.
You on vacation already.
Femoral necks are parallel. Yeah, I know. I'm ready for a few days
Are your
off.
kids off for this?
They are. They're all out having fun. I think they're doing like a city pass today, just going and doing a bunch of stuff. Lucky. She's called in sick today.
That means no teachers would have been here
For
today.
real.
That would have
That
been.
means no teachers today?
No, we would have Miss
I always
Vince.
have Miss Shepherd come in here and entertain me.
Entertained. So they would watch a movie the entire time.
No, I'm not gonna do that to y'all. We got important stuff to do. All right. So central ray perpendicular to the femoral neck. We're not gonna add an angle on this. This is showing you basically how to place that CR. This is the complex curriculum-based way to place your CR. But as you guys learn in lab, there is a little secret method, at least I hope they showed you in lab, to centering that properly on the patient. How'd y'all learn in lab? What'd they show you? The crease of the leg, yes. Y'all know what I'm talking about with the crease of the leg? Did everyone learn that in lab, by the way?
Yes.
When you bend the leg up, there's a natural crease.
Yeah.
You want to put your central ray on top of that crease, of course, mid-shaft of the femur. If you put it on the crease, you're going to put it directly on the femoral neck. It's a lot less stressful than trying to put the pencils and the pins and all that measuring stuff. That stuff always stresses me out. I'm like, well, there's an easier way. Let's do it the easier way. Find the crease, put your central ray on there, relax the leg, and you're right on that femoral neck every single time. It works like a charm. Do make note, once again, guys, if we know there is an orthopedic device, any kind of hardware in that leg, we have to include the entire thing. So we need to make slight adjustments according. That would be centering a little bit lower to make sure we get that entire appliance on that x-ray. If it's extra long, we might need to go up to a 14x17 cassette to include the entire appliance. Depending on the patient. Some of you won't know until you shoot the x-ray either. But regardless, if we're cutting off part of that appliance, we need to repeat that x-ray to get all on one image. But in most common cases, that is going to be a regular 10x12 cassette. That will be lengthwise, by the way. We're going to do a lengthwise 10x12 cassette. That's going to change when we go to the lateral, so we're going to turn the lateral crosswise. Think about how the leg shifts position between the two. AP is straight down, long. Lateral is to the side, so sideways cassette. You know that anatomy orients. Yes?
Is this the 2 and 4? 2 and 4 down?
Yeah, with the pencils.
It's the form right doing it like that.
I don't know why he. That overcomplicates it for me. I'm like, yeah, I can do all this bigger stuff, but no, crease, it works every time. Why am I wasting my time? It's a lot quicker.
I asked him, I said, how do you want us to do it for test doc? He said, however you need to do it.
As long as you're on there, he doesn't mind. Yeah. Besides, I always feel like if I'm going to a patient and centering on them, and I'm pulling all these pins and stuff out, I don't look like I know what I'm doing. I look like I'm a student still, and I'm not confident. Like, if I just like center it, like boom, 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 like, hey, this guy knows what he's doing. That's just me. I never used any of that measured stuff after I graduated. Like the caliper. Like they used to make us use calipers when I was in school. When I was in school, I'm gonna tell you some of my PTSD from my school here. You're gonna get me off on a tangent again here. They made us do calipers for every single exam we did because every exam we did, especially the ones we comped on, we had to do what was called skin doses on every patient. So you would get your measurement, then you would put your measurements into a formula, algebraic equation. So every comp had a sheet of paper. Every comp I did had a sheet of paper on the back of it where we had to write an algebraic equation and calculate skin dose based on our measurements of the part. And that was part of the grade as well. If you got that wrong, you failed the whole comp.
Who was your
I started to sweat. It stressed me out so much in school. Yeah, it was hardcore. Yeah.
So that's just off of like you're measuring exposure per comp, like that.
So you would take your measurement, then you would plug that into the formula, add your techniques as well, your KVP and mass, and you would calculate the actual patient's skin dose.
That's cool.
No, it's not. No, it is not. It's a waste of time because you can get it off the machines anyway, and Yeah, they were just trying to torture us.
Are we gonna be
They hate
able
us at
to
school.
learn how to do that?
No,
Oh, good.
no, that's that's obsolete now. Count your blessings.
Don't
Thank
be
you,
adding stuff to the
Jesus.
curriculum.
No. Yeah, there were so many ways they could fail us. Like if we didn't measure with the calipers, it was an automatic fail. We didn't shield, it was an automatic fail. We missed our marker, automatic fail. It wasn't a repeat, it was a fail. You got a 0 on the exam. If we missed our imager view, like if we missed one piece of imagery, it was a fail. These teachers were psycho in my program. Like they enjoyed seeing us suffer. And I say that seriously, they enjoyed to see us suffer. Did I tell you what they said the first day? Have I told you about my school?
No. What?
I don't know.
It did like a
Bits and
little bit,
pieces.
but it's been a while.
The first day of school in my X-ray program, we were sitting in an auditorium at the university. They walk in, you know, all like, we're the most awesome people on this planet. You're privileged. You know, you ever see those really cocky, stuck-up professors? You walk in there, all like chest puffed out. I just want you all to know this room. Look around this room. Half of you are going to fail this program. You see these 20 people in here? There's only going to be 10 by the time you graduate. We're all like,
Like, should I pick another school?
yeah, yeah.
Or, like,
Anyway, I'll tell y'all more stories later, but that was death. I always said if I ever became a teacher, I would never, ever treat my students the way these teachers treated us, because it was unnecessary. I knew what I was doing when I got out of it. Like I knew how to do some X-ray, but good Lord, the mental damage that program put us through was rough. McNeese State University, stay away. If anyone's going to that school, tell them to come here. It's a lot less.
Is it still bad?
Yes. Yes, it is. And there's still two of the 4 teachers are still there. Maybe they've gotten a little better. I don't know. 2 of the 4 teachers are still there. Anyway, let me get back on the subject here. I'm gonna start having nightmares again. I used to wake up in the middle of the night, by the way, having nightmares when I was in that program that I didn't get my comps done and I was gonna fail out of the program. Because with Louisiana, you guys are so blessed because you know we're in Houston and the population is so high that you get a pretty good steady flow of patients. In Louisiana, we'd be sitting there looking at the track board because they have a screen up in the department where the exams would populate. We'd just be sitting up there like, please let something come in. Please let something come in. We'd be sitting there for hours. Oh, please just let a chest come in, something. I need a hand, let a hand come in, somebody please. It was stressful. There's not a lot of people in the Lake Charles area compared to here, so we were at the mercy of that. And we still had the same requirements as you guys had. I think we had more actually, because they eliminated a lot along the way.
It's grown some since then, right?
What?
The Lake Charles.
It has, since they've added like the casinos and all that stuff, it's brought more jobs, but anyway, let's go back on the subject. I'm getting stressed out talking about this. Bad memories. Alright, what are we looking at when we look at the hip? Structure shown, head, neck, trochanters, and proximal 1/3 of body femur. I will add this to your notes because it is considered optimal when you do an AP hip. What we see in this picture right here is that we have included the pubic symphysis. Now, a lot of your texts will cut this off, but per optimization of an AP hip, you want to make sure that pubic symphysis is also included on that radiograph. It's considered the optimal way to get an AP hip. So everything you see there plus that pubic symphysis is very important. That's a very pretty AP hip, aside from that digital marker there.
Okay, so you do want both the trochanters.
Huh?
But you do want both the trochanters in there, even though you're trying to hide the lesser as much as possible.
Because yeah, and the reason it says both is because remember how I said some people, it doesn't matter how you turn their foot, it's gonna stick out a little bit. Different anatomy on different people. But if you can hide it completely like you did here, that's a good thing.
You're still able to see the shadow of the lesser through the.
Just barely, yeah. Just barely. Gosh, you get all these bad memories coming back. I remember sitting in a test out when I was in school. You know how you do all those test outs. We did them too. Except my teacher, she would like get all up in your face. Her name was Miss Young. Most evil professor I ever had. She had her clipboard. She had these big glasses. She would put them on the end of her nose and like look at you with like this condescension, like she hates you. And she'd have her pen. She'd be like right here with the X-ray table, looking at you. all up in your face when you're in position. Like all snide, giving me the stink eye. I remember there was this girl I was testing with. Her name was Jennifer Bruce, and she just went blank because of the stress hit her. She just like burst into tears. I was her patient. I'm sitting there like, oh my god, like, I wish I could help her. Like, I can't move her. If I even move her and blink, that she's gonna fail me. And she just burst into tears, and she's like, "You better stop crying right now. You're gonna fail out of this program. You better get your act together. Get with it." I'm just sitting like, oh god, like I haven't even went on my turn yet. I was like, oh god.
They're tearing up too.
She kept crying. She finally got her act together, and she barely passed that exam, but oh, I think it gave me heart palpitations thinking about it. But yeah, she was so strict, Miss Young, and she would part of our test outs for lab was we also had, you know, I give you your image review tests where you do the hot spots. The way it was for me, she had have you seen the little X-ray light upboards they put films on? You know what I'm talking about? Old school light boxes. So you would do your test out portion, and in between that you had your image review. So our image reviews were linked with our test outs. It was really weird how they did it. But she would purposely find the ugliest freaking X-rays on the face of the earth. Old school film, by the way. And you'd be looking at these things like, what? What even is that? Is that a hip? Or is it a foot? Like, you couldn't even tell what some of the stuff was. And she'd have these little obscure lines with letters on them. You didn't even know what she was pointing at half the time. If you asked her, she's like, you just need to look quick. You just need to look closer. You're supposed to know that. I don't want to hear any questions from you. You're supposed to know it. Just do it. So on top of that, we each had a clipboard of our own, and it had like 1 through 50 with blanks. So we had to walk around to the light box with our pencil, and it'd be like this. These are letters, and like this is letter A. You had to write with perfect spelling, by the way, I might add, or you failed the whole question. Greater trochanter of the right hip. Costophrenic angle of the right lung. Like you had to put like everything was a sentence. It was horrific. So anyway, let me get back on subject. That was intense. Yeah. Yeah. So thankfully we got technology now. I'm not making y'all write that stuff out. Do our hot spots, a little less stressful, more close to the actual registry. But yeah. Anyway, what was I talking about? I'm going down memory lane here this morning. Evaluation criteria of the AP hip. So what do we want to see? Of course, collimation if necessary. Just like with the pelvis, guys, open collimation usually on a hip is sufficient because most people have larger hips. And it's going to fill up that cassette anyway. So you can afford just to leave that collimation open unless they're just very, very small. You see a lot of extra light on the side of the hip area. We want the regions of the ilium and pubic bones adjoining the pubic symphysis. So, like I said, we do want to see the pubic symphysis as well. That's considered optimal for that radiograph. If that was clipped, by the way, you wouldn't necessarily repeat it, but you're going to have a suboptimal image according to the curriculum. You want to include that pubic symphysis if possible. We want the proximal 1/3 of the femur, the entire long axis of the femoral neck, not foreshortened. We achieve that by doing what? How do we have femoral neck not foreshortened?
Don't dangle.
I'm correct. What do we do?
Rotate.
Rotate the foot. That's why we rotate that foot inward. That elongates the femoral neck and puts it parallel with the cassettes. We do want the greater trochanter in profile. Lesser trochanter as invisible as possible, or rather superimposed on that femoral shaft, so we're not visualizing it, although sometimes it will still stick out a little bit. It's okay. It does say very small amount visible. That's still considered optimal. Can't help it on some people. And any orthopedic appliance in its entirety. So a lot of evaluation criteria on that little x-ray there, but all very important things. All little factors coming together.
So if we complex something like this and we brought it back here for interview and we cut this, would you?
I would take points off, yes. It wouldn't fail, but it would take a few points off, because it is considered more optimal to have that on there. Good question. I'm also gonna turn Miss Young and fail you for everything. What's your centimeter measurement on that? Where's my skin dose?
Is it like 2.5?
I will say, as much as I have traumatic memories of that program, it did vastly prepare me for the job. Like when I got through X-ray school, like I felt like on day one I was an expert. I knew exactly what I was doing. Like we try to do for you guys too. And that's probably the only positive aspect I can say.
Just without the meanness.
Without the mental trauma, yes.
I'm too emotional, so I think you
What that means.
Boy, let me tell you, if you had feelings in that program, they got crushed. It was like, I feel like we were like in the Marines or something, like screaming at us and trying to fail us constantly, breaking us down. So unnecessary. There's still a lot of teachers out there that like to be jerks like that. That doesn't work with today's clientele. You gotta adapt for new generations. So many teachers are not doing that. That's why I'm doing that speech at TSRT.
I was about to say, aren't you doing a speech?
Yes, I am. Yes, I am. Because there's so many of those old school teachers that are just so caught up in that old mindset. They want to evolve. It really bothers me. It really bothers me. Well, I'm just talking about everything but the lesson today. I'm so distracted. Okay, let's talk about that Lowenstein and Hickey method. Award the best name of the semester, yes? Lowenstein and Hickey. Yes, that's a name that sticks, right? All right, so this is basically our lateral hip x-ray. Now keep in mind when we say lateral hip, we are not turning the actual pelvis lateral, just like with that frog leg we talked about. We are putting the femur in a lateral position. So it's the femur hooking up to the pelvis, thus showing us the hip joint. It's a lateral hip, and we do that by abducting the affected leg. Now, if there is a fracture, which is why we always do the AP first, by the way, if there's a fracture, you're going to omit this x-ray. Why? Well, you're going to make that fracture worse, and if there's a dislocation, you're going to make the dislocation worse. They're probably going to be screaming at you anyway, freaking out, so don't force that leg. Patient will still be supine. We're going to rotate very slightly. This is a little bit different here, by the way, guys, different from the frog leg. Remember the frog leg, we wanted them flat and supine. For the lateral hip, we do want to rotate them slightly to the affected side and put it into a more lateral position. Excuse me. That's going to depend on how much you can abduct the leg. If the leg can be brought all the way down like you see in the picture here, because the patient is very flexible, then you're not going to rotate them at all. If they can maybe bring their leg halfway down, you'll rotate them the rest of the business and try to bring that leg down close to that IR as much as possible. Make sense? So we got to think outside the box a little bit there, and you know, it's going to change per patient. And you can see our situation directly on the crease. You can even see the crease on the leg there. Still the exact same central ray. But what's different? Look at the cassette orientation. Remember I told you on the AP is lengthwise? And you see how we switch it to be crosswise here to match the orientation of that part. It's not going to be a wide view. So we're going to turn that cassette crosswise. When it comes to those cassette orientations, always think about the shape of the anatomy or x-ray. It's a little indicator to show you which way you turn that cassette. Like between shoulder and scapula. I know a few of y'all had trouble with that. Scapula's long, shoulder's wide. And you know, usually not available, but if you have something to prop their leg up, help them get a little comfortable there. A little pillow for their other leg. It'd be nice if we always had this stuff, but no one seems to want to invest in it. All right, so park position. Center that affected hip to the midline of the grid. We're going to flex the affected knee and put that femur parallel to the table. Body of the femur parallel to the table. Opposite limb will be propped up because we may have to turn the patient, oblique them slightly, depending on how much they can bring that leg down. And rotate the pelvis to accommodate the flexion of the thigh. Once again, that's if they can't rest that leg all the way down. We'll rotate their body to accommodate for that and try to get it as flat and lateral on that table as possible. Also to reduce that OID. Because if the leg's not flexed all the way down, there's going to be slight OID on part of that femoral shaft. femur will be considered parallel to the table. Yes, the body of the femur. Just think like the femur is a line, and the table is a line. It's a parallel line. You know, parallel versus perpendicular. Alright, central ray will still be perpendicular through the hip joint. Now, by the way, with these two names, when we're talking about just the Lowenstein method, it's entering midway between the as-is and pubic symphysis. That's basically directly on that hip joint. We have the alternative method. Now, I would not recommend doing this. You're never going to see this asked on your registry. You're never going to see this done in real life. We are going to stick with the Lowenstein method, which is the way you did it in lab, but the Hickey method is going to be a cephalic angulation of 20 to 25 degrees. Boy, that would make a really good bonus question. So Lowenstein and Hickey, they put the names together, but they also describe two different ways of doing the same exam. Lowenstein is the way we're going to always do it. I've never seen anyone do the Hickey method. I think it's a terrible name too. It might be a terrible thing to say to a patient who's walking in the room. Hey, we're going to do the Hickey method on your hip here. But we're going to do the what? So it's weird how they classify it. They put them both together as a lateral hip, but each name is describing an alternative method of achieving the same thing. They get a little funny with these names sometimes. They'll put them under the same exam even though they're described in two different ways. And sometimes they just isolate them by themselves. I don't know why they do that. Ten by 12 crosswise once again for that set orientation. All right, so what are we going to see? Of course, the lateral projection of the hip. We're also going to see the acetabulum, much more visualized because the way we're going to move that femur out of the way. The proximal end of the femur and the relationship of the femoral head to the acetabulum itself. That's a way we can check for that dislocation, which we do not see dislocation at all on either of these. This is showing you side by side of someone who could not bring their leg all the way down versus someone who does. See how it puts the leg horizontal versus kind of angled? Both are okay, but this would be the more optimized view that you see right here. Now, different from that AP, you do not need pubic symphysis on this one. We already achieved that on the AP. We're only interested in this area right here, right at that hip joint. By the way, this kind of shows us here, if you look closely, look at how the obturator foramen is closing off. What does that tell us?
The hip.
That they did what with this patient?
The weight.
They rotate to the right slightly. You don't see that? And then you can't really see the full all of it. It is more stretched out, more enlarged.
So they rotate it to the right?
They rotate to the right, yes. So once again, for hip and pelvis, whenever a patient's oblique, we go oblique to the right, the ala gets larger and the obturator foramen closes off. If I'm turning left, the left ala enlarges and the left obturator foramen starts to close off. So one part gets larger, the other part gets smaller, kind of inverse to each other. All right, so the evaluation criteria, of course, star of our show is the hip joint. Thus, we want the hip joint itself centered to the radiograph. We want to see the hip joint, acetabulum, and femoral head, and femoral neck to be overlapped by the greater trochanter. And we'll usually see it poking out on both sides. See a little bit right here, and especially down here. We want the femoral neck free of superposition and bony trabecular detail. So of these evaluation criteria, the one that's going to be most important is this right here, femoral neck overlapped by the greater trochanter. That's when we're using that method without the angulation. If we are using the angulation, we'll see the femoral neck more stretched out, like you see right here. And once again, this is not an ideal method by any means. I've never seen anyone ever do this method right here, but it does exist. I guess if they really want to see that femoral neck elongated, they might press that, but I've never seen that happen. So most of your doctors won't know about it, so don't mention it. Would you like a hickey method with that? No.
It was freezing it. We're definitely in.
Now that y'all are becoming such masters of anatomy and medical work, is it harder to watch those shows now?
Yes.
You see all the mistakes in there? I can't really ever watch any medical show anymore because
I'm like, oh,
there's
that is
so
not
much
sterile.
stuff wrong.
Nothing is sterile.
Maybe the
They don't even get the names of the
doctors
stuff
are always
right.
doing the ones where they yeah.
I remember one time they were calling carpal bones tarsal bones and like all kinds of stuff.
They just said that like the doctors are the ones that do the
Doctors do all the
MRIs.
x-rays and the MRIs, yeah. Techs don't, rad techs do not exist in the medical drama world, Hollywood, apparently.
Here's the next one.
I used to watch House all the time, you know, a House show. And I remember seeing them push the x-ray machines and taking the x-rays. I'm like, wait a minute, that doesn't ever happen in real life. It'd be nice if it did, but that was the only one I could bear though, 'cause I like the mystery aspect of it.
Of House?
House, I like trying to figure out what the disease is. It's like Sherlock Holmes medical drama, you know? That's hilarious. I found it hilarious.
I like that part about it.
All right, my favorite one, guys, and everyone's least favorite one in lab, but it really is a beautiful x-ray when done right. The fabled, the awesome, but not very intimidating in real life. Demilius Miller, I'm trying to sell it to you.
You got they funky feet all on the x-ray.
And Black Friday deal today.
Black Friday.
This x-ray is not as bad as it looks, guys. I know there's a lot of moving parts to it, but I'm telling you, if you can master this exam, you will be the love of all the radiologists out there. If you can deliver these to them, because most of you people come in the trauma room, they have busted up fingers, busted up hips, and so many techs are just unwilling to deliver this to the radiologist. They just do an AP pelvis and send it in. If you can deliver this, guys, you're going to be that radiologist's best friend, and you're going to be proud of yourself because it is a beautiful x-ray when done correctly.
Can you actually show us the next, like, I want to know what it looks like. Yeah.
You know,
Like
the
what,
x-ray?
yeah, like what's
It's
the
coming
difference
up.
between,
It's coming up.
Have any of the seniors actually gotten this?
Yes, they have. In fact, I'm told Victoria over at LBJ is pretty good at making these appear.
Making these appear?
Yeah.
What is that supposed to mean?
In other words, if you bring it up to her, she can make it appear. If they order a hip X-ray, I mean, think about it.
she
This
can
is just another
justify
way of
it.
doing a lateral hip. So you can do an AP hip series and throw that in there and still get a lateral hip.
Bless you.
It's all about what the tech's comfortable with, but unfortunately, a lot of techs are scared to death of this X-ray. I do not know why. I do these on kids all the time. They work with the charm.
You said Victoria at LBJ?
Victoria LBJ, yes.
Since the one that goes missing.
She makes them appear.
It's gonna go
outpatient, right?
Appear.
Appears,
Yes.
appears for the.
Anyway,
hips.
make note, guys, because this is a registered question. The only reason in real life, by the way, not when we're searching for comps, in real life, this is only done as a trauma view, is a trauma X-ray. Thus, it being cross-table, trauma or surgical. I didn't add that, trauma or surgical, because sometimes you'll go into a surgery case and they'll want this as a post-op film. They used to call me for these all the time in surgery, when they put that hardware in. So trauma or surgical cases only.
Gold star question.
Huh?
Gold star question.
That is a gold star question. That's on the registry. I have confirmation of that. Now, part position. We're going to elevate the pelvis for our third patients. We're going to flex the knee and hip of the unaffected limb to place thigh vertical. By the way, even though you see on this picture, the patient has their leg rested kind of on the tube, we do not do that anymore. That has been removed. I learned in school to put it on the tube. They've since stopped doing that. Does anybody know why? It's kind of common sense, right?
They moved it too.
Nasty. Sanitation,
Yes.
harming the equipment,
Got that gout.
and has anyone felt how hot those tubes get sometimes? If you put their foot on the wrong part of that tube, you're gonna burn their foot. That's just kind of stupid, right? So we don't put them on the tubes anymore. Thus, we either prop them up or we have someone hold that leg out of the way. Now, for me, I always get someone to put a lead jacket on and say, hold that leg for me. Just hold that up. I'll get a nurse, hey, you, come hold this leg for me. I put the nurses to work. Or the doctors, hey, you want this x-ray? Come hold this leg for me. You gotta get rough with them sometimes. Get someone to hold that leg for you, out of the way, because we're gonna shoot through the crotch, essentially. That's why it's called the crotch shot sometimes. I think Miss Bonilla said she called it the crotch shot. I always call it the crotch shot too. We're gonna rest the unaffected leg on a support or hold it out of the way. And unless contraindicated, we're gonna rotate the affected limb 15 to 20 degrees. Now let me put a little disclaimer here. Because this is almost always done as a trauma view, you're almost never gonna rotate that limb. Why? It's likely that the femur is shattered or dislocated. That's the reason you're doing this. But if for some reason you already know through confirmation that everything's fine and they can do so, rotate the limb to put the trochanters in the right orientation. But not likely to happen. As it says, most exams are contraindicated, thus trauma view.
Are they not holding their leg up by themselves? Like, since I know it's
Well, think about it. In the trauma room, do you think they're gonna hold their leg up out of the way for you? Not very
It
likely.
didn't seem that way. I don't know why. I just thought that they
I don't
would be.
remember hearing if it was for trauma or surgical.
I remember he said it was trauma, but I didn't know like that was the thing with like resting it or somebody holding it. I thought you just hold it up and lay there, like lifted up.
I wouldn't
He said you
recommend
come
that.
back, like you let them put it down, and then like the only time you let them like hold it like by themselves is like he said you run to take the X-ray and then come back.
That's not a good idea.
It's uncomfortable.
Those nurses aren't doing anything useful. Make them hold that leg up for you. They're just playing on their phones all day.
Come here,
Pretending
Donna.
to work, right? Huh?
Come here, Donna. You ain't doing it.
I'm so rude.
You've been
I've had some
all day.
bad nurse experiences. I have no idea. Like I said, there's some good nurses out there. There are some very good nurses out there. I work with some terrible ones.
The ones that
Have you ever had the light bulb bust?
mine were.
Well, at least you had good ones.
The light bulb on the tube.
Those EC nurses, Lord have mercy.
Mr. Donahue, have you ever had the light bulb bust on you? Like go out on you?
For a tube? Yes.
Did
in
it scare you the
fact-
first time?
Yeah, it kind of startled me. Yeah. I've seen bulbs go out. I saw a tube shatter on top of a patient
What?
once. Tube exploded and the glass fell on top of the patient. This is to say that was a lawsuit on the hospital. The patient did not get hurt, but they sued the hospital. They were doing a fluoro case and the x-ray tube, they were doing plain films, and I don't know what happened exactly. I guess it just didn't have proper maintenance. The tube shattered on top of the patient.
Which KVP?
That's why you need biomed to do maintenance on this stuff. Wear and tear, it's a real thing. Equipment. The scariest one I saw was I walked into it was room 5, GE equipment. This room we all hated it because it was always glitching out and having issues. But we walked in there one day. The tube was facing the floor. We kept smelling something like it was burning. So we walked in there, and there was oil coming out the tube, like scalding hot oil. It was like burning a hole in the floor, like it was
What?
smoking. Yeah, I was like, thank God that was not over a patient when that started leaking. But yeah, there's like super hot oil in those things. That was the scariest one I
Just
saw.
imagine if that
Even though-
thing was right
yeah,
there.
yeah. Anyway, like I said, we're talking about everything but the subject matter. this
Could we
morning.
roll up the sheet? And I know you said we wouldn't have the patient hold their leg, but would we be able to have them like kind of pull on it
I
slightly?
wouldn't recommend that.
Okay.
I'm just telling you, it's a fail-safe. Have someone hold that leg for you. Put some lead on them. Put them to work. Make them help you out. Okay, so as you can see, why is it called the crotch shot? Because we're aiming for the crotch or the femoral neck. So once again, you're kind of aiming for that crease of the leg. A little bit hard to see from this view, but we are putting that situated directly on the femoral neck. The cassette will be vertical with the upper border in the crease above the iliac crest. We do have to angle it slightly away until parallel with the femoral neck. So we have to try our best, and you have to eyeball this a little bit. There's no fail-safe way to get this just right. You learn to eyeball it. You gotta turn that cassette to match the orientation of where that femoral neck is. When you develop your superpower to that x-ray vision, you'll be able to do that a lot easier. So we are gonna angle that cassette slightly, and then I will, if the patient's conscious, have them hold the IR, put their hand on there, but once again, not always possible. Thus, you might need someone holding the leg and someone else holding the cassette, probably you, while you have the trigger, holding the cassette, pushing the button. That's what I had to do a lot. But don't depend on that patient to do everything for you. This is an ideal scenario, that you see in this picture. It's not gonna be likely for most of your real life cases.
Do you mostly do this one like on a portable machine or something?
Yes,
Oh.
because trauma. In fact, I don't think I've ever done one of these in the actual X-ray room. I think I've always done this portable. I like that though because the portable machine's a lot more flexible, a lot more maneuverable. It's actually harder to do these with X-ray tubes, in my opinion, in the actual rooms. You have less maneuverability. Now, biggest thing people missed on this exam right here. Because we are matching the orientation of the cassette, going cross table, this is considered a perpendicular and horizontal central ray. Are we angling the tube? Yes, we are, but we're matching the orientation of the cassettes. Thus, it's considered a perpendicular central ray because it matches the exact orientation of the cassette. Does that make sense? Also, key word, when you see that word horizontal, that's key for cross table. We're shooting cross table. We're putting that on that long axis of that femoral neck. 10 by 12 cassette. Shouldn't use a 14 by 17 for that, just going to be excess radiation on the patient. And it's going to show our acetabulum, head, neck, and trochanters. It's really weird on that picture. X-ray tubes do not look like that. I don't know what they were trying to draw there.
Like just the beams.
That was more like a dentist X-ray tube.
Yeah.
And they're X-raying your jaw. So once again, y'all see how they slightly angling that cassette? This is to learn how to eyeball. There's no exact science to that. Just make sure that the top of that cassette is in the iliac crest. That's the one no one wants to draw next to me.
You know it.
But you have to do it for capstone. It'd be good practice. Yeah, no lab this week.
So if we had lab, or I guess we're all just gonna report to clinic at 7 a.m.
Yes.
7, 8,
It's a normal full day. And you get some 3 days off. It's well earned, right?
Well, at least you have to study.
It's good study. Eat lots of good food too. Enjoy time with your families.
Can't wait.
Don't send me any text messages. Unless it's happy Thanksgiving.
I was just gonna say. I was just gonna say. Not
Pictures of
even
food.
happy holidays, happy
No,
Thanksgiving.
if you have an emergency, I'll always answer. It's no big deal. I'm joking.
What's up? Quick.
Have you had the burger joint over in
Yes.
Montrose? Yes. Have you tried the turkey burger for Thanksgiving?
I haven't tried the turkey burger.
It's good.
That place is
I'm-
good though.
and I'm
That
not-
is some
I'm not a
good
turkey
burgers.
fan.
Like, I know, like there's a million different types of burger places, but that place makes some really good hamburgers. The whole menu's good. They put one in by the Baybrook Mall.
Is
The
it?
one I'm going to,
Okay,
yeah.
cool.
By the way, you want to see what it looked like? Here's what it looks like. Very similar to a lateral hip because it is a lateral hip. It's just an alternative means of gaining the lateral hip. Look at that. She was wanting to know what it was, not even looking. Huh? Over here talking. That's what you've been waiting for right there. The moment of truth.
That's it?
That's it.
I'm thinking it's like some brand. I don't know.
That's very pretty. You don't think it's pretty?
Yeah, it's pretty.
That's
It
pretty
just looks like
X-ray.
She said it's really not.
No,
Looks like a
you will notice that this combination is circular. Does anybody know why that's circular?
To the CR?
That's a OR.
We all learned that
I
in
mean,
PRE.
not OR.
No.
CR?
Yes, a CR.
Good guess, but no.
Oh.
This is a very old X-ray. This is film. They used to have circular apertures that would go in the tubes that could allow for circular collimation. But since obsolete, they don't do that anymore. But if you ever see an X-ray with a circle around it like that, it's likely a very old exam that you're looking at. Now,
It's a good.
evaluation criteria. Of course, the hip joint with the acetabulum, that's the star of our show. We're doing a lateral hip. Small amount of the lesser trochanter on the posterior surface, or not at all. We preferably want it superimposed. We want a small amount of the greater trochanters on both sides. And remember how I told you on the anatomy review, guys, we're going to see the greater trochanter coming out on both sides on this exam. Now, if it's not ideally positioned, you will see some of that lesser trochanter down here, but if it's ideally positioned, it will be superimposed a little bit higher. Regardless, you will see the greater trochanter poking out on both sides. Keep that in mind because people always forget that. Y'all see that here and here? The greater trochanter is great, it is large, it's going to poke out on both sides. And then the all wonderful anatomy, I keep telling y'all to remember that ischial tuberosity, very nicely visualized on the bottom of that film there. Acetabulum, femoral head, deck. Nice little Donahue Miller. Do not let it intimidate you. Show off to those techs if they're scared of that x-ray. You're better than that.
Hey, I'm not doing it. Maybe I'll just, where is that? Who is his ass? Got joke for 2 kids, alright?
That's, hey, you gotta laugh at that.
I got joke for 2 kids.
Oh, wait, I'm sorry.
Oh, you're still writing?
No, I'm almost done.
You're drawing a picture.
Yes, sir. You're good.
You got something creative on that one you're gonna make? You always have some kind of meme or something.
Oh,
We're liking in our jokes. I don't like to erase all our jokes and stuff up here. We need to
Who did that?
fill the board back up.
I'll come up with Sorry.
All right, a few more evaluation criteria, guys. Ischial tuberosity below the femoral neck and head, and any orthopedic appliance in its entirety once again. So there's another example of a Donahue Miller. Ischial tuberosity down here, greater trochanter, neck, head, acetabulum. Yes.
You know what's funny? Yesterday I saw a tech doing portables with a C-arm.
Yesterday?
Yes.
On Sunday?
No, I'm at work.
Oh, it's your work.
I asked him. He's like, you can do it, but he doesn't want others to know that you can do it because it's a pain in the ass. Apparently.
Wait, all right. So explain this to me again. What exactly are you doing?
He's doing a portable with a C-arm.
Interesting.
I guess all the other portable machines are occupied. And he was struggling driving that thing
Full-on
too.
C-arm.
Full on C-arm. I
He's
asked him
taking-
too. He's like, he said it's not normal, but you can do it. But he doesn't want anybody else to find out that you can do it.
Something he shouldn't be doing.
That's just
Those mini C arms are cute.
where is this?
Remember Herman Sugarland?
That's all I needed to hear.
Uh-uh.
Memorial Herman. that's all
Say
I
no
needed.
more.
That makes a lot more sense now. Oh Lord Jesus, have mercy.
Yeah, you gotta be.
All right,
you thought
case
outside the
point,
box.
ladies and gentlemen, do not ever take x-rays with a C-arm unless you're in an actual fluoro case. That is very foolish. It's
Alara,
lucky
do
to
you?
have a license doing that.
Oh really?
Yeah, you can get fired for something like that. That's unnecessary radiation exposure to the patient. That's high dose.
Yeah.
That's very foolish.
That's
Yeah,
not
don't
good.
ever do that. All right, so if we cannot do a regular Donahue, let's say you have a patient coming in trauma room and both legs are shattered.
Ooh.
I can't move that leg out of the way, but the doctor's still saying, hey, I want that lateral hip. Well, your really lazy techs will be like, well, I can't move the legs, let's write on documentation, you can only get the AP. But in reality, if we were smart and thinking outside the box, as you guys all are, because you're gonna be experts by the time you graduate and the best at what you do, we have what's called the modified axial-lateral hip, Clement's Nakayama, in which we can still obtain a pretty good visualization of that lateral hip by making some slight alterations to how we do it. So based on the picture, what do you think we're doing, essentially? What do y'all think's going on there?
Cross table lateral or something.
It's cross-table lateral and we're angling into the parts.
Yeah.
And just basically trying to distort it enough that we can get a visualization of it. So it's not going to be optimal by any means, but we can still obtain a semi-decent lateral hip by thinking outside the box a little bit. I bet you most of your techs don't even know this exists right here. If you brought that up to them, they'd look at you like you're crazy. But it can be done. So why would we do this? Bilateral hip fractures, like I said, they come in the trauma room, both legs are busted up, you can't move them. Bilateral hip arthroplasty or limitation of movement of the unaffected leg. That's the only reason you're going to do that x-ray, those 3 reasons right there. Otherwise, you'll do the Donahue Miller exam because it's more optimal of the 2 views. Patient position, supine with the affected leg near the edge of the table. Both legs will be straight out. They can't move their legs. Main thing we're gonna do is we're gonna top, the top of the IR will be tilted back 15 degrees to accommodate for the angulation of the tube that we're gonna add, which you see is 15 degrees as well. Top of the IR tilted back 15 degrees, still at that iliac crest, by the way, just like with the Donahue Miller.
Can we do this in place of the Donahue Miller? Like on the, as a comp? Like, since,
I wouldn't recommend it 'cause it's not the prettiest X-ray. We know the picture's gonna look pretty good on here, it doesn't come out very good. There's a lot of superimposition of tissues on the part, it's just less than ideal.
okay. Cause I'm thinking that like this would be a more rare exam, right? Or
Yes.
rare, okay.
Yes.
If we possibly got a good image like this and this is only like,
It still counts as an axiolateral, if that's what you're asking, yes. But this is what we call a last resort X-ray. Last resort.
sounds cool.
It's not considered the optimal exam. We always want to optimize our images as much as possible. It smells kind of good.
You said that-
Winterberry Wonder. Does it cause lots of wonder on the hands?
Buy for your wife.
Does it fall down kind of?
You buy for your wife.
She likes the vanilla.
I think that's
The
a,
vanilla
like
scents.
a mom thing, 'cause mine likes the Korean vanilla, warm vanilla.
Like the warm vanilla sugar.
Yeah, yeah, okay. That's my favorite.
Oh, I know.
Oh, okay. He's like,
I know what's up.
Yeah, you, hey.
You good?
Yeah.
Zoned out? Yeah.
Everyone, you know what's up too.
Hey, who is yours?
That's my earphone.
All right, central ray, guys. Now this will be an angled tube, so different from the Donahue Miller, which was considered perpendicular. We are angling 15 degrees posterior and perpendicular to
It's less than
the femoral
technical,
neck.
but it's still.
And this will still show the acetabulum, proximal femur, head, neck, and trochanter. That kind of gives you a little visualization of what's going on there. Angling down into that part, into that angled cassette, to throw that joint onto the film.
You said this looks adjacent to the Donahue Miller?
It's an alternative if they can't move either way.
But a harder.
It's a suboptimal exam. If they really want that lateral hip and they have no other way, there is a way. There's always a way. It's one thing I want to really teach y'all is the techs, because some of those techs you work with are like, well, it's just not possible to get that X-ray. I don't want those words to ever come out of your mouth when you become a professional, because there is always a way to get a good film. You just got to think about it a little bit. Think outside the box. You can make your own views up. You can. Don't think it has to only be Merrill's. I've made up a lot of views myself. I still get a pretty good X-ray.
So there's a Donahue
Be
lateral on
creative.
there?
Oh, yeah. Like that foot, I showed y'all that upside down foot.
Like your pencil foot? That one?
Well, that one too, the sunrise buttocks, I mean, it doesn't even exist, but it was a made up exam.
Why are you doing that? Where's that from?
Oh, you weren't here. So this is a patient came with a butt, with a butt.
That's rare.
A patient came with a pencil in her butt. And the
That was
doctor
funny.
with the sunrise buttocks. So I had to put the film in front of the butt, angle the tube into the buttocks and throw that up like a sunrise patella, that was the butt, to see where the pencil was, to make sure it wasn't puncturing the rectum.
Like, it was in somewhere or like just stabbed in her?
It was stabbed in her butt, and they were afraid it was puncturing the rectum. It was like, I think they said it was like 3 centimeters.
How'd that happen? She
Off.
fell?
Nope.
It was a
The
prank.
student put a pencil in her chair, and she sat on it.
About to do the
That's
gym.
crazy. 'cause
And that's how she
that was
arrived. She
really
arrived with
cool.
her butt up in the air, just like that on the stretcher.
You
That
gonna
was
be,
weird.
you gonna be upset when I
She
know
was
this?
14.
He was right. You don't even feel it.
All right, and as you can see, guys, it looks like a Donahue Miller, but the quality is going to be more compromised. It's not going to be as pretty. It's a little bit more muddled, higher contrast. We got some tissue down here from the other leg. Suboptimal exam, but still delivers the results if they're really wanting that lateral hip and there's no other way. So we want to see the hip joint with the acetabulum. We still want to see the femoral, head, neck, and trochanters, and any orthopedic appliance in its entirety. based on that third bullet, or fourth bullet point, is this an optimal exam?
Nope.
Why?
The
Yes.
orthopedic
No.
appliances.
We cut off the appliance,
Yeah.
right? Which I'm surprised with as much as they preach this, they put that in the book. You know, but optimally, we need to have that entire appliance on one single X-ray. Yeah.
So, when I was in bone clinic and we couldn't get a certain appliance in, like we tried to expand as much as we could, let's say for a hip, Amy or whoever else my tech was at the time would say, well, they need to order a femur as well, so that we can, you know, like expose the patient to pretty much show the entire femur. It looks like they got the, you know, proximal 1/3 of the femur. Would they have to ask for a femur X-ray in addition, or?
Do you know if it's like super long?
Yeah.
Yes, you would.
Okay.
They would add that onto the series.
Or would you just send 2 pictures?
No, so you're never gonna send 2 with a split. You have to show it all on one. So in the cases of a super long appliance on a femur, you'd likely have to utilize what we call stitching or partitioning.
Mhm.
Have y'all seen that, like with Scully X-rays or anything like
Mhm.
that yet? When they stitch the images together? Same concept. Some of the machines are capable of doing that partitioning or stitching method to make one single image. All right, let's take our first break. It's 9:01. Go ahead and take about, I'll give y'all 15 minutes. It's a holiday week. Take 15 minutes. We'll start back at 9:16, and we'll wrap up with our special projections.
Do you know how your daughter